So I'm going to focus a bit on a different aspect of the problem from Rob McKenna. Not so much on diversion, a little bit more on the national context than specifically on what's going on in Washington, and to really try to look into what are the links between increasing use and abuse of opioids other than diversion. So Greg gave me the title, Dying for Pain Relief, which I think is appropriate in the sense that the mortalities associated with prescription drugs are really what put this issue on the map. I'll tell you that probably like a lot of you, I go looking through Google Images to find the pictures I use on my slides, and luckily Alex Kahana worked in Geneva, Switzerland before he came here, so he was able to rat me out on this. Of course, this sign has nothing to do with pain. In Geneva, this is a French bakery that Alex used to go to when he worked there. I'll let you figure out what the word for bread is in French. Didn't have anything to do with pain, but we're Americans, we don't care. Another European who happened to work for workers' compensation in Prague, I thought had something to say quite relevant to what we're talking about. Franz Kafka, in his somewhat macabre story, The Country Doctor, wrote, "To write prescriptions is easy, but to come to an understanding with people is hard." I think this could be put above the door to our pain clinic, because I think this is all about the challenge of pain medicine these days. So what I'm going to generally do is to talk about the relationship between prescription opioid trends that we've seen over the past 20 or so years and what we've seen in terms of risks. And what I'm going to focus on, to just give you all the up-to-date acronyms, COT has to do with chronic opioid therapy, which is a different animal than acute opioid therapy, which you might get after your wisdom teeth are pulled out or after you've had an appendectomy. We're talking about 90 days or more use. CNCP is chronic non-cancer pain, so we're not talking about palliative care in the traditional sense of cancer or end-of-life care. We're talking about generally non-progressive chronic conditions such as low back pain, joint pain, neck pain, etc. So what we know about opioid use is that it doubled between 1980 and 2000. Many states passed intractable pain acts legalizing the chronic use of opioids in the late 90s. And so this use of opioids doubled again between 2000 and 2010. We estimate that somewhere around 3% of the entire U.S. adult population, around 10 million people, are on chronic opiate therapy. Now, much of this is intermittent and low dose, so it's a few Vicodin a week for granny who's got a sore knee. There is also a growing number of people getting quite high dose with potent drugs, and we'll talk about them later. So what Rob McKenna has talked about is that across the nation, not just in Washington, but throughout the nation, this has now become the most common cause of accidental drug overdose. It exceeds motor vehicle accidents in 8 states, including our state, and it's also the fastest growing form of drug abuse. And unfortunately, it's much more lethal than, for example, marijuana. So what I'm going to claim by the end of this talk is that these trends in use and abuse are linked through something that I'm calling adverse selection, which is that through mechanisms we don't entirely understand, but I have a hypothesis about it, high-risk patients are selected for high-risk therapy, and those patients are also at highest risk for bad outcomes. So this is, I would say the 30 or 50,000 foot level. This is milligrams per capita of morphine in the United States of America between 1980 and 2007. I could have shown you identical slides for oxycodone or for methadone or for virtually any opioid. It's not a particular opioid, but there's rapid growth. It's not even linear. It's curvilinear with an accelerating use pattern up through the 2000s. It turns out, like many not-so-data-based medical practices, that there's a wide variation across states. This is a paper that came out in 2006 having to do with private insurance claims for opioids, and the shading darkness has to do with all Schedule II drugs. Those are the most potent opioids, and then because of OxyContin being an issue of particular interest. The crosshatches have to do with how high the rates of oxycodone are. And as you can see, in our state here up in the corner, it was basically in the 4th quintile of overall opioid use. It was in the 5th quintile of oxycodone use, and that had combined to make us one of the highest death rate states. They're scattered around. It's not really easily apparent why given states are higher than others. Number of surgeons per 100,000 population seems to be associated. Something about the age distribution and the economics of the state also seems to be relevant. This is another study that looked at state Medicaid programs. It's a slightly different pattern, but once again, we're up not in the black shading, but in the dark gray. Some other states in our region, like Alaska and Montana, are even worse, with, again, a high variability in opioid use. And there is a similarly high variability in bad effects that tend to follow along. Rob McKenna talked a bit about Gary Franklin, and I think credit for the new state law has to largely sit with Gary, who was noticed and was alarmed about the increasing deaths in the labor and industries population. He noticed that as opioid doses climbed in the late 90s and early 2000s, he began to see injured workers dying who did not have lethal diseases, and he was quite upset about that. Another person who has been alerted to and working on this issue quite hard is Jeff Thompson, the state medical director for our Medicaid program. His staff published this paper in the Mortality and Morbidity Weekly Report that the CDC puts out. I'll just go over it a bit. So among Washington Medicaid enrollees from 2004 to 2007, nearly 1,700 of that group had died from opioid-related overdoses. So who are these people? Well, about 60% of them are male. About a third of them are in an age group that you wouldn't think would be dying from anything, really. And 45% were enrolled in Medicaid. So given that's really overrepresented of Medicaid enrollees in this death group. For example, the age-adjusted rate of death per 100,000 was 31 in the Medicaid versus 4 in the non-Medicaid population, which an age-adjusted relative risk of between 5 and 6. So that means equivalent Medicaid patients had 5 times the risk of dying compared to non-Medicaid patients. And what drugs were they dying from? 3/4 or 2/3 had methadone, another quarter had oxycodone, and then about 15% had hydrocodone. So methadone is also documented in other states to be problematic with overdose. Unfortunately, it's the opioid least prone to abuse, but most prone to overdose due to the fact that it has complicated pharmacokinetics, complicated dose conversions. It can dose accumulate. It's not an easy drug to use in a safe way. So I'm going to talk a little bit about our research. Greg alluded to the fact that the National Institute of Drug Abuse has been funding our research for a while. We were looking at the period between 2000 and 2005 in a Medicaid program in Arkansas and in a Blue Cross Blue Shield program across 14 to 15 states. And we noticed a few things I'm going to briefly summarize here, which is that chronic use, that is, we're defining that as more than 90 days of use, 90 days supply in some instances, in some of our analyses it's 90 days of continuous use, is increasing at twice the rate of any opioid use. So the chronic use is especially growing, and it doesn't really matter which chronic pain condition you've got. The back pain people and the joint pain people and the headache people are relatively similar in their rates of opioid use and chronic opioid use, but patients who have more than one pain problem, that have both back and neck pain or both back and joint pain, the multi-pain group have higher rates, and in fact, the rates of chronic use double with each additional pain diagnosis. In fact, opioid use is concentrated in the patient population like no other pharmaceutical, partly because opioids have no absolute ceiling. People become tolerant, and you can endlessly increase the dose. You can ask Greg during the break about the kind of doses that he's seen. You would think they'd need to be in wheelbarrows rather than in medicine cabinets. In one sample, our Blue Cross Blue Shield sample that was privately insured, we found that 5% of the chronic pain patients consumed 70% of the total opioids in a given year. In a Medicaid population where there's much higher base rates of illness and disability, 5% of the pain patients consumed nearly half of the opioids. So it's a phenomenon not so much of the big middle, mean, median part of the distribution curve, but the tail. The patients who are most distressed, most ill, are getting most of the opioids and are also suffering most of the risks and the deaths. So I happen to be a psychiatrist interested in pain, and so I'm always interested in the mental health and substance abuse disorders in the pain population, and they turn out to be pretty important in the opioid issue. So in 2000, at the baseline, when we started our study, chronic opioid therapy was 2 to 3 times more common among those with any mental health or substance abuse diagnosis. Okay, in our Blue Cross Blue Shield sample, it was 8% versus 3%, and in Arkansas, the Medicaid sample, it was 20% versus 13%. And not only did they start higher, they rose faster. So between 2000 and 2005, it increased more. 35% versus 28%, and 55% versus 40%. So this is a group that is getting more opioids. You can see this graphically here with our 2 samples here, and in each case, the dark bars, which are the groups with mental health and substance abuse pre-existing problems, are getting prescribed at a higher rate for the chronic use, and it's growing more quickly. I also have worked with Mike von Korff and a team at Group Health who've studied trends in Kaiser, Northern California, and Group Health here. They have found very similar things in quite a different healthcare setting, quite a different population. What they've found is that incident, that means new chronic opioid use, and then ongoing or prevalent chronic opioid use rates were 3 times higher in patients with a history of depression. And when you get to substance abuse, the story is even worse. Prevalent chronic opioid therapy among patients with a history of depression. Well, this has to do with depression again. Let me get to the substance abuse later. So it's starting higher and it's increasing about twice as fast, 7 to 13% in Group Health and 8 to 12% at Kaiser. Not only are they more likely to get it, they're more likely to get a high-risk regimen, meaning those with history of depression get a higher daily dose, greater days supply, and they're more likely to get the high-potency Schedule II drugs. So that's that pairing of high-risk patients with high-risk regimens I was talking about. So this is moving from the depression patients to those with a history of substance abuse. So people who have an SUD, that's a substance use diagnosis, at Kaiser Permanente, Northern California, it raised from 12 to 17%, whereas those people without the diagnosis, the rates of chronic opioid therapy went from 3 to 4%. Similar in Group Health, 8 to 19%, and the group with a substance abuse diagnosis, 3 to 4% without. Those who had a diagnosis, you would think that patients with a diagnosis of opioid abuse per se would have lower rates, but in fact they have the very highest rates of opioid use. At Kaiser, it grew from 44 to 51% of these people are on chronic prescription drugs, and it escalated at Group Health monumentally from 16% to 52%. In addition, like the depressed patients, the patients with substance abuse disorders get higher doses, they're more likely to use the potent Schedule II opioids, and they're more likely to be concurrently receiving sedative hypnotics like the benzodiazepines. And if you think for a minute, you'll realize that both the opioids and the sedative hypnotics can suppress respiration. And in fact, that's thought to be an important factor in these deaths. You've got multiple drugs, all of which can stop patients from breathing, and that's the primary mechanism of death in these unfortunate overdoses. So the trends are generally that an increasing number of patients with chronic pain are getting chronic opioid therapy. The duration and the potency of chronic opioid are increasing, but not the average dose per day. So as I told you, this is a phenomenon of the tail. The median has been quite moderate at about 35 milligrams of morphine equivalent a day. And we're quite amazed throughout the various disparate samples we've been studying. That's a pretty constant number. But what's happening is that the very highest dose use has really expanded. And these largest increases are in patients with mental health and substance abuse disorders, which we've called an adverse selection of combining high-risk patients with high-risk regimens. It turns out that death is really just the tip of the iceberg in terms of risks of chronic opioid therapy. There's a wide variety of risks. I'm not going to talk about all of them today. But in addition to fatal overdoses, there are probably 10 times as many non-fatal overdoses. It looks like elderly patients in particular are more prone to falls and fractures. I'll show you a little bit of that data. Patients on chronic opioid therapy are more likely to be making emergency department visits. There's been a great increase, according to the CDC, in emergency department visits for prescription drug problems. They're often combined with alcohol and other drugs. Among this group, there's high rates of opioid misuse. Opioid abuse and dependence are also increased. The group also has various adverse effects from the opioids that we've begun to study with our prescribed opioid difficulty scale, both psychosocial problems and the fact that this group is very concerned about the fact that they're on an addictive substance. Even if they don't meet criteria for what we would call an addiction or a substance abuse problem, people are worried about being on these medications themselves. So Rob McKenna alluded to this. This is CDC data about poisoning deaths, 1999 through 2006. If you look at the various bars as we go through the years, they're all pretty much the same width except for these bottom dark blue bars, which is specifically opioid analgesics, are the ones that are increasing in rates concerning poisoning deaths. And as you can see, there's been a substantial growth from around 20,000 to nearly 35,000 in 2006. And these have continued to grow since 2006. And again, there's a lot of variability across states about which have the highest death rates. Unfortunately, we're right here. Part of the rate significantly higher than the U.S. rate, and we're one of 8 states that has the dubious designation of having more deaths from prescription drugs than from motor vehicle accidents. And I don't think that's because we're better drivers. So epidemiologists love to show trends. There are all these lines, and they would love people to believe that just because all the lines are going in the same direction, that they're all connected. But in fact, the connections, the mechanisms, the causal links are sometimes obscure. And I'm going to go over a couple of recent prominent papers about the connection between opioid use and deaths that told quite different stories about why this is happening, just to give you a sense of what's going on, because I think both of these papers are true about a certain aspect of the problem. So the first paper I'm going to talk about was done by Hall and basically Leonard Pelosi's team from CDC. They looked at opioid deaths, nearly 300, in West Virginia, which is, of course, where the whole OxyContin, hillbilly heroin snorting issue came to light to start with. So 300 opioid deaths in 2006 in West Virginia. 2/3 of these are men. 92% are in 18 to 54-year-olds, which are not the usual chronically ill palliative care group. And what they found is that 63% of these individuals who died had no prescription. So they were getting diverted drugs. They were buying them off the street. They were getting them from somebody who had gotten them otherwise, but they were not getting them from physicians. There was another smaller group, 21%, generally women, who had evidence of doctor shopping, meaning that they had, in the recent months, more than 5 prescribers. So it looked like it was predominantly diversion in men and doctor shopping in women. So the implication of this study is that the deaths are from bad behavior on a part of the patients. They're not doing what we're asking them to do, and they're dying as a result of it through diversion and abuse. I mean, who knows how many of those prescribers knew that the patients were seeing multiple. And this made it look like it was really a problem that needed to be addressed through changing patient behavior. Another study done by Dunn et al., this was Michael von Korff's team at the Group Health Cooperative. I was on this particular paper myself. And this really takes a different tack, which points toward the fact that the opioids are inherently risky medications. So it's a very different population looking at group health cooperative members. So group health cooperative members tend to not be extremely poor nor extremely rich. They're pretty middle class, and they also are relatively selected for being employed and stably enrolled. So this is a more mainstream population. Looked at nearly 10,000 persons with 3 opioid scripts over 90 days. And over the 12 or so year period that we looked at, there were 51 opioid overdoses with 6 deaths. And what we were able to show in this study is that overdose rates were increased by prescribed dose. So we're not talking diversion, we're not talking doctor shopping, we're talking what's the relationship between what you put on the prescription and how likely the patient is to die of overdose. So the patients on really low doses, between 1 and 20 milligrams per day, had a low rate of death. That nearly increased 10 times. It was actually 9 times for those on over 100 milligrams a day. And so this paper, along with subsequent papers from Ontario and from the VA, which have been published subsequently, indicate that there is inherent risks with prescribing doses over 100, or in another paper 200. So it's not exactly the same number, but it's clear that there's dose-dependent risk of overdose with these drugs. This is another paper from Mike von Korff's team that I worked on, and this is showing you that there are increased hazards in the group over 60 for fractures. A lot of these were hip fractures requiring hospitalizations, and as you can see, as you go from 0 with a hazard ratio of 1, by the time you get to 50 milligrams or more a day, you've doubled the risk of fractures. So there are other non-mortality related health risks that are significant in this population as well. We've looked at emergency department visits. They've been exploding according to the CDC, doubling or quadrupling in the past decade. They occur quite frequently in people on chronic opioid therapy. They also get seen specifically for alcohol, drug, intoxication, and withdrawal problems at lower rates, but this is a more specific diagnosis. Substance use disorders in this chronic opioid therapy group are associated with both emergency department visits and these alcohol and drug visits. Mental health disorders were associated with these ED visits in one sample and the alcohol and drug visits in the other. Dose per day was not so much related to the emergency department visits, but was related to these visits for intoxication, overdose, or withdrawal. And it's interesting, we're going to get the FDA REMS, which is a risk evaluation mitigation strategy, is specifically focusing on the long-acting drugs, the OxyContins, the extended-release morphines, the extended-release hydromorphone. And that is the group that seems to be particularly associated with these diagnoses of intoxication, overdose, or withdrawal. But it's actually the short-acting drugs that were more associated with emergency department visits. And we may, if we see regulatory pressure here, we may see more events related here. So I think Mr. McKenna kind of alluded to some of this national data about abuse. I'm not going to go into greatly, but to just show you that the National Survey on Drug Use and Health, focusing on those over 12 years old, showed 5% use of non-medical use of prescription opioids, more new initiators in 2006 than any other drug besides marijuana, most obtaining from friends or family. He talked about some even higher figures than this in terms of the number of 12th graders misusing opioids. And as I mentioned, we're seeing many more opioids in ED visits. We tried to look at misuse in a very 30,000-foot way, and we calculated a score based on people getting too many days of drugs, too many prescribers, and too many pharmacies. And we generated a graph like this. This is shows you that as your opioid misuse score derived from number of days, number of prescribers, and number of pharmacies goes up, your chance of getting an opioid abuse diagnosis goes up. And as again, I'm going to tell you that this is a phenomenon of the tail. So most patients are in here with no evidence of misuse. That was 70 to 76% of both samples. And it's about a 2% rate here of getting some misuse. Another group is what we call the gray zone, the possible misuse, and this is another quarter of the sample, and they're now having misuse rates of around 5%. This group here is the group that's really having a lot of trouble. It's only 3 to 6% of the whole sample. Abuse rates are now up about 15%, and these are gross underestimates of the real problems, and you can see that basically these things increase together. Misuse and abuse go together. We have been interested to see that there's a fairly easily understood connection between people with other substance abuse problems and having opioid misuse. People who've misused alcohol also tend to misuse opioids. Interestingly, people who tend to smoke cigarettes also tend to misuse opioids. But we really didn't know what was the connection so clearly about depression and misuse. So I've worked with one of our residents. We have a paper in press now about this, based on a survey, and we asked about 3 kind of classic forms of opioid misuse: self-medicating for non-pain symptoms, self-increasing dose, and getting or giving opioids from family or friends. And we concurrently measured depression. What we found was this, and this is percent of the group here. So it was quite common that people used their opioids for sleep or stress. Those were the questions we asked. And that may or may not be considered an abuse, but it's certainly a broader sense of what opioids are to be used for than strictly pain. And we found some relationship with depression here. We've got the lowest depression scores here, elevating up to a very moderately level of clinical depression here. But as you can see, this non-adherence, or people who get early refills, they're using their drugs more often than they should, that's strongly related to depression. And so depressed patients are more likely, they're more distressed, so they're more likely to be using these pills. Interestingly, in terms of getting meds from others, giving meds to others, kind of more your classic antisocial substance abuse stuff, is not really that clearly related to depression. So I'm going to go quickly through this because Greg is glaring at me. So I want to say one other interesting thing. So once you get on chronic opioid therapy, you have to realize that the group who gets chronic opioid therapy is highly self-selected. Most patients given opioids don't like them. And if you look at naturalistic samples, people quit. The majority of people quit because either it doesn't work or it's not worth the side effects. And so it's a relatively self-selected group once you get to people who are receiving chronic opioids, particularly the group that we studied here, which is the group that's used at least 90 days without a gap. So these are probably daily or near daily users. What we looked at is also a fairly significant endpoint. We said, once you get on that, how often do people really stop? And we took as a measure of really stopping 6 months with no opioid prescription. And we were kind of surprised with what we found. First of all, in both of our samples, once you get, I assume you guys know what Kaplanmeier curves. This is 100% of people started out on chronic opioid therapy, and then over time, we get people quitting, and this is the rate of quitting chronic opioid therapy by our definition. And the thing I want to draw your attention to is the fact in both groups, less than half quit up to 5 years later. So once you're on for 90 days, you're likely on for 5 years. And maybe a lifetime. It's a therapy that I believe is self-perpetuating and tends to basically create the need for its own continuation. I think a lot of patients in particular have magical beliefs about if you give me, some pain pills to relieve my pain for the next month or two, doc, then I won't need them anymore. I don't think that's true. Unfortunately, the kind of things, the most potent predictors of continuing to use drugs are dose, and here's our Blue Cross Blue Shield sample, and as you can see, the green group is the group that's over our state dosing guideline, and they're more likely to stay on quite a bit more than the other two groups. Also true in the Arkansas group. Dose predicts continuation, and unfortunately, the other thing that predicts continuation is misuse. So we've got our misuse score. Remember, that's based on excess days supply, excess prescribers, and excess pharmacies. So here's this group with no misuse, and they quit at a quicker rate. These other two groups with some misuse quit less quickly in Blue Cross Blue Shield and also in our Medicaid population. So these are the risks that we've talked about in terms of chronic opioid therapy. These are the risks, many of which have been shown to be dose-dependent. So my hypothesis about how use and abuse are connected is the following. Opioids have inherent risks of abuse and overdose. There's a high-risk drug component. It's somewhat potency-related, somewhat duration-related. It's related to how long you're getting it. Opioids have been prescribed to patients with high rates of mental health and substance abuse problems, and it's important to know that all the efficacy data, almost without exception, is based on trials where these patients were excluded. So in fact, when we talk about efficacy for these drugs, we don't have efficacy data on the sample that's being treated in actual practice, at least not this high-risk sample. And what we're calling that combination is adverse selection, which is a combination of high-risk regimens to high-risk patients. So here's really speculation, but this is based on my 20 years of clinical experience. So providers, meaning us, want to help patients in pain, and there's few tools that we know as well as the prescription pad. It's right there, it's easy to get to, we don't have to make a phone call, we just write something out. Patients with mental health and substance abuse problems are more distressed. That is, they're more likely to have pain complaints. They're more likely to have associated problems, meaning insomnia, anxiety, depression, and they're more persistent in demanding opioid continuation and dose increases. This is the group, unfortunately, that likes to stay on the opioids. And the providers, that's us, use our opioid prescriptions as a ticket out of the room. A lot of these patients can be angry or demanding or very distressed. We want to do the right thing. We don't know what else to do. We hand out a prescription. So we have to figure out what we should do next. Thank you.